Good afternoon, everyone. I'll be presenting on persistent diagnostic challenge, managing an evolving case of optic neuritis. So, what do we know already about optic neuritis? We know that it is an inflammatory disorder of the optic nerve presenting with acute vision loss, pain with eye movement, and visual field defects. It is often associated with demyelinating conditions such as multiple sclerosis, but can also occur in autoimmune, infectious, and nutritional disorders. So, the diagnosis requires a comprehensive workup, including neuroimaging and laboratory tests, to determine the underlying cause and guide for appropriate treatment. The aim of this presentation is to report a fascinating case of unilateral optic neuritis in a young male that continued to pose diagnostic dilemmas, showcasing the complexities in its diagnosis, and to analyze differential diagnosis of optic neuritis, highlighting the need to distinguish between various causes for accurate diagnosis and treatment. So, this is a case of an 18-year-old male who presented with sudden onset unilateral diminution of vision in the left eye from past 4 days after waking up in the morning. On systemic history, there was no history of any similar complaints in the past, no history of any systemic illness, no history of any similar complaints in the family. He was vegetarian by diet, takes adequate sleep, and there was no history of any allergies or addictions. On ocular examination, the visual acuity in the left eye was decreased. It was 6 by 24. Grade 2 RAPD was present, defective color vision and contrast sensitivity. Extraocular movements were full, free, and painless in all directions. The right eye was within normal limits. On dilated fundus examination, right eye, the fundus was normal. In the left eye, blurring of optic disc nasal margins with a hemorrhagic spot near to the disc was present. Macula and rest of the fundus was within normal limit. So we did an automated perimetry. Right eye was within normal limits. In the left eye, there was an inferior altitudinal field defect respecting the horizontal meridian. On further workup, we did a fundus fluorescein angiography, which showed normal dye filling in the initial stages, but in the later stages, it showed disc staining in the left eye with minimal leakage, suggestive with disc edema. We did an MRI brain plus orbit plus 2 mm optic nerve cuts, which showed bulky retrobulbar and intraorbital segment of the left optic nerve with enhancement suggestive of left optic neuritis. The VP was also increased pre-100 latency in the left eye with decreased amplitude. So after doing a multidisciplinary approach, we got a neurology consultation. We did a CSF lumbar puncture to rule out any infective cause, and systemic infectious and autoimmune workup including ANA, ANCA, VDRL was done, but all the tests came out to be negative. Serum anti-MOG and NMO tests were also done, which were also negative. So what did we found? We found the oligoclonal bands were also absent in both serum as well as in CSF. Low serum B12 levels were present. Increased serum immunoglobulin levels were there, but it was non-specific. So based on the above clinical findings, the most probable differentials were first was multiple sclerosis. If we take respect to the age, unilateral optic neuropathy, and the MRI was consistent with demyelination, but the oligoclonal bands were absent. He was vegetarian and the serum B12 levels were low, so that was consistent with B12 optic neuropathy, but there was spontaneous improvement before supplementation. Third differential was NAION because of the sudden onset unilateral vision loss upon waking, hyperemic disc, and altitudinal field defect, but ischemic mechanism was still not clear. On further course, the patient was planned to start IVMP, but on second day of admission, spontaneous improvement in vision was noted with resolution of fundus changes. So the patient was kept on annual follow-up and given injection B12 injections. At 1 month follow-up, the visual acuity was 6 by 6 parts with mild red desaturation. Discussion. This case of unilateral optic neuritis with acute vision loss, optic disc blurring, and inferior altitudinal field defect posed a diagnostic challenge due to overlapping features between atypical and typical optic neuritis. Differentiating demyelinating as well as other causes of optic neuritis is crucial to guide the treatment. This case highlights the complexity of diagnosing optic neuritis and a need for a thorough multidisciplinary approach to understand its diverse etiology, which is crucial to prevent mismanagement and optimizing outcomes. Thank you.
Thank you. Very good presentation, and it's unfortunate that we cannot mark you for it this time. And we hope that, of course, it amplifies the importance of becoming AIOS members early. And we hope that in future you will be here for an award.
Yes, sir.
What was the final diagnosis for this patient?
So we couldn't reach to a definitive diagnosis still, but we are suspecting among these three causes only.
Sure, I guess. But you didn't give any treatment.
No, sir.
So
We give
this is
B12 injections.
I hope that was not the therapeutic intervention that was there. I mean, I don't think the patient. I mean, did you check for B12 levels prior?
Y- Uh, During our workup, we checked the B12 levels. It was low.
Okay, so
Yes, sir.
well, B12 is also known to cause visual dysfunction. But thank you very much.
All
Thank
the
you, sir.
best.